I'm going to introduce you now to Tim Hanley, who I had to read what his role was because it was changed. He's the General Manager in the Safeguarding of Vulnerable Persons at Risk of Abuse team, and he is going to give a talk about the Safeguarding Policy Review.
Good afternoon, everybody, and this is definitely the graveyard shift. I definitely have felt like a Spice Girl the last couple of days. I don't know how much social work I did leading up to yesterday, which we had the expert panel with Professor Shute and preparing for today's Learning and Development Seminar. I felt like an events manager, phoning, emailing and texting people, and it was like, tell me what you want, what you really, really want. Bear with me as I go through some of the slides, and there's a lot in this, so I'll try and hit the key points. Before I do that, I just want to make a couple of comments. Thanks to the Western Care, and can I wish your colleague Tom well in his retirement. Those of you that don't know, Tom Hughes is the Head of Education and Training. I'll miss his 4-page emails. I'll miss his half-hour telephone conversations, but Tom has been a wonderful leading light for adults living socially valued lives. And I personally have learned a lot from Tom, and he invited me up one afternoon to look at the incident management system in Castlebar. So I certainly will miss him as a very kind of valued colleague. Just a couple of other points, because I will forget to mention them later on, is that we do have attendance certificates, so we'll email those out to everyone that attended, because I know people, it's important for your CPD points. I suppose I was struck by, I say the word courageous leadership and values in action, that people like Catherine, like Maggie's team, like the people in Western Care, the work that was done down in St Finbarr's Hospital, change doesn't come easy, and it is hearts and minds. So in my office, I get in a number of emails, phone calls, I go to meetings, and I see a lot of the problems, and people tell me what's wrong with the policy. I hope I'm open to listening. But what I really find wonderful on today is the inspiring people who've been brave enough, sometimes in huge, challenging environments. So I say that to the safeguarding teams. Some of what they've had to do hasn't been easy. They've let out on the policy. The people in the funded agencies and public health nurses, members of primary care teams who've been doing this work, people in the elder abuse service for many, many years, have been doing it well before the policy, but we needed a national framework. That was really, really important. So I think I've learned a lot today. I'm going to try and go through as best I can just a little bit about why we're reviewing, and I think it's kind of apparent that there are reasons to review this policy, and a little bit about where we've got to date on this journey. Okay. The Review Development Group started in January of this year. We've heard that the policy came in, and it did come in rather abruptly. As I said, there was work been ongoing in terms of a national sectoral approach in the disability field, and there had been an older persons policy in 2007. But events were quite compelling. There was little opportunity really to listen to managers and practitioners. There was a commitment to an early review of the policy. Martina, who you met earlier this morning, is chair of it, and Martina's shown huge leadership in that process. I suppose we were tasked, and there's a number of members of the Review Development Group here this afternoon, and were here yesterday hearing Michael and the expert panel, and that's part of the review process. So we were tasked with a number of things too. I suppose first thing was, how is the current policy operating? I mean, how well is it doing what it should be doing, and where is its weaknesses? I think we've heard a few of those, and where is its strengths? I think the second thing we were asked to do was to consult widely and to hear back from managers, practitioners, but importantly service users' own experience of safeguarding, family, relative organisations, our trade union colleagues, our staff organisations, our organisations like their Association of Social Workers, advocacy organisations, to look at what was being done internationally, but from a policy point of view, and a legislative point of view and models of safeguarding. And come up then, here's the easy bit, to take all of that and redraft a policy that's better. That's the one test. And not only should be better, but should be better for the service user. I suppose we were asked to look at a couple of key considerations that from a governance point of view, there was strong accountability and alignment. We heard a lot this morning about capacity legislation, and we need to be clearly aligned with things like the mental health and the capacity legislation. The other thing we were asked was to consider the risks. Every change has sometimes got unintended consequences. So, change not for change's sake, but change where we can use as much evidence, as much feedback in terms of revising it. I think the other thing we were asked to look at what people, to listen to people's experience and as best as possible to apply that, both based on that and the evidence and the knowledge that already there. So I will be going around the country, and I kind of apologies for a number of you that have been at workshops already, and you may have heard a lot of this, but some of you may not. Okay, so we undertook I suppose we project planned this, which was rather unusual, and those of you that kind of know the internal workings of the HSE, the mystery that it is, we have a quality improvement division, and they appointed a chap called John Lamont to assist us in terms of project management, and people mentioned Colin Kelleher, who we have as an external consultant. Colin's also been advised. But we were advised to do this on a phase basis. Phase one, look at what was out there internationally. Draw up a project plan and map out stakeholder engagement. Look at what people think of the current policy. And then carry out a governance analysis of some of the strengths and weaknesses from an accountability oversight point of view. And communicate work, I got this at the right angle, communicate work that we're doing. So hopefully I'm here today, and communicate out to key stakeholders in services and organisations and how we're doing our role. So what did we find in phase one? As I said, we undertook 3 subgroups. I should have said that. It was in the earlier slide. Pauline, who's down there in the room, Pauline is led out on the research and evaluation group, and they commissioned the work that Dr. Sarah Donnelly and her team in UCD has undertaken, and many of you have had copies of that report. I think we might have 1 or 2 more hard copies, but we certainly will be circulating and are circulating that extensively. I chair the consultation group in terms of how we go out, finding out what people think and hearing from people regarding future options or changes. The third group is the EASY group, and that's chaired by, some of you will know, Jude O'Neill. He's the head of social care in, I'll get this right now, Laois, Offaly, Longford West Meath and Meath and Louth. Did I get that right? I hope I did. So we've taken it in 3 sort of subgroups. Okay, what do we find coming out? And Pauline will recognise some of these slides because I've copied them from her. So thanks to Pauline. So what do we learn from the research that Dr. Donnelly and the team in UCD, and a lot of this you've heard already from Michael this morning. There is a move towards with a paradigm shift. As we know, with the capacity legislation and the mental health legislation, it's now human-based report-based approach. I certainly, my social work training would have been from a best interest that I knew best. I knew best for the service user. So now we're looking at what's in human rights. I think the other thing is that we need to be very minded about compliance, process-driven case management. And I remember my practice when I started out as a young social worker back in Glasgow in 1991, and we used to have a thing called the Blue Book. And my area manager did nothing, and I mean nothing, without consulting the Blue Book. And every time I asked him, he said, did you follow procedure? And it was in the Blue Book. So internationally, the move now is looking at, as Mike was talking about, making safeguarding personal, what is the outcome that the service user wants, and a more focused and nuanced approach. And also with managing risk. We can't eliminate risk, we have to manage it often. I suppose as well, thought zero tolerance is hearts and minds. It's an ethos, and moving away from a kind of a procedural-driven zero tolerance and looking around professional judgment. I heard Michael talk a lot this morning. How is decision-making made? What process? What questions were asked? And what proportionality was applied to that? So also looking in that our intervention, is it person-centred? And how are we supporting and involving the person as much as possible? And sometimes mediating or resolving. As we know, often people will say, I want to mediate an outcome. It's not always about eliminating the risk. It always tells us about how we organise ourselves. Is it about the service or is it about needs-led? And that's, as a leader in the health service, I suppose that's something I need to continually be reminding myself of. And equally, the kind of risk-adverse. Are we risk-averse? Are we too much on the risk-averse side and not looking about shared responsibility around decision-making? So that was some really important, and I suppose none of that will come as a surprise to you as practitioners and trainers on the ground. Key messages from research, I'll go through this quickly. We need to consider how best to support the service user in our engagement, and we heard about engaging the service user, listening to their lived experience. And how do we measure this? Question for us all. I suppose the continuum between, we heard a bit this morning about the continuum between prevention and protection. And I certainly saw that from my time in child protection, that we sometimes were putting many of in the response element. I think Catherine talked about were we response driven or were we preventative driven? And looking at the match between the definitions of how we see abuse and harm and where we place our resources. And I'll come on in a moment to talk about who is this policy for and what are we protecting people from. And that then sets our considerations of our resource base. We heard a lot today about it's not just training and rolling it out. And I share some of your frustrations around the KPIs. I get constantly asked for quantitative figures. And really, the point that the people from Western Care there made, Dave and his colleague, about spreading and embedding. It is about, did we give it meaning? Was it embedded? Did people understand it? And where was the long-term change? I suppose the other bit that was clear in the research was that interagency cooperation just doesn't happen by chance. Just because Tim Hanley calls a meeting, everybody will turn up. I think what was said in the research is that we need to ensure that organisations are meeting, sharing and collaborating. And that, to me, is a really important message from the research. Other key things that come out: should we change the language? Vulnerable person, vulnerable adults. Is it the right word? And I've heard a lot in relation to that already in our focus groups. And I'm going to be really interested to hear what the service users, persons with disabilities, older persons, people with sensory disability, physical and sensory, think about that. How do we really embrace the capacity message in the ADM about will and preference and preferred outcomes and the need to protect? I think that was a constant theme, and that came up both last night with Susie Bray's presentation on self-neglect, is how do we get that balance right? And I'm still asking myself that question all of the time. The other thing we asked, I suppose, Sarah and her team was there a silver bullet out there in terms of what's the best model? Was she going to give me the answer and give the review? So there wasn't any one answer in that one. We have a number of options which we need to weigh up and consider, but there was no one. I suppose the other thing to make there is there was nowhere like Ireland in the world. We're very unique in how we organise and deliver our services, so there was no comparative internationally. And I should have said that they looked at 5 international English-speaking countries. Mentioned earlier about where do we position the response on the preventative, protective continuum, and that's going to be really important in coming to revise the policy and getting that right. Mandatory reporting, we can't avoid it in terms of, is it right? Does it conflict with person-centred? And the whole question I heard last night and earlier today, the duty of care to respond, and then, as we know, is there of being kind of mandatory, obliged to respond and report it. So we need to be very careful to look at that. And is there international evidence that mandatory reporting works? And certainly some of the things we've been hearing was that it has a conflict with person-centred and proportional responses. So we need to look at that. It's also a message there for the legislators. And we were joined last night by Senator Susan Kelleher, that's leading on the legislation. What the research has given us is some models, and we'll be out talking to teams, to safeguarding teams, to HSE, primary care, acute care, out to mental health teams. It's a challenging piece to look at reforming of our model. There's so much change and restructure continually happening. Now, one person has already said to me at one of the sessions, she said, I was just getting used to safeguard teams, and I was just getting used to terminology, and now you're talking about changing again. So I think we have to look at what model or variations of a model, and there are different options between a very specialised, centralised safeguarding right through to a very dispersed, and then into a generic, a very dispersed generic model of safeguarding. So there are options for us in the revision of the policy. Some of those we need to be mindful, though, that we can only influence so much. There is constant reform and restructuring of services, so we need to influence in the best way possible. I think some of the questions, and I pulled this, I suppose, questions myself in relation to, and it echoes some of what we've heard today, is when we come to revise a policy, do we need to change the language? And I continue to ask myself, who is this policy for, and who are we protecting, and what are we protecting them from? There are different, when we looked at internationally, there are different responses that trigger a state response. So there's different levels of mistreatment. There's also different states or jurisdictions have set up different reporting thresholds. We need to look at that. Scotland has a threshold based on harm. England has a narrower approach based on abuse and neglect. Who needs protection? The vulnerable person. And a lot of people have fed into us from, we like that term because it's easy to explain it out there to the public, right through to some service users and older people and persons with disabilities tell me they feel it's very stigmatising, and they definitely don't like the term. Should we move to a new term? And if we move to a new term, it will change the scope of the policy. So should we talk about adult risk of abuse, adult risk of harm, and they're different concepts, and so the meaning will bring around a change. Again, the whole question of what we're protecting people from, is it another person who's abusive behaviour, the context of harm, or the issue which has come up a lot about undue pressure or influence. And also then, if we extend, where is the home, as Michael said, for self-neglect? Lots of questions there. And also in terms of our terminology that we're currently using. And I just give one example, as those of you that know, preliminary screening is in both the trust and care policy and in the safeguarding policy, which causes no end of difficulty, as many of you will know if you're managers. And also the language around assessment, investigation and inquiry. We need to get more clearer and have professional practice guidelines around what we're doing. And that message actually came out quite strong from Dr. Donnelly's research. I just wanted to talk a little bit about some of the messages we got from the governance group who did some workshops in relation to strengths and weaknesses, and the survey we did, and many of you in the room will have taken part in the survey. What has that told us to date? And looking and putting that alongside Dr. Donnelly's research is giving us a roadmap for revising and then editorially looking at what changes we should make. We carried out a survey. I just think what really I found great about this was I was had a bet in the office of how many people would answer the survey, and I thought about 2,000 people, and I was kind of laughed at. But we actually got, I think in total about 1,800, but about 400 people opened the survey and saw nothing to do with me and closed it. So we actually had 1,400 people responded, which was the second highest survey undertaken by the HSE. I think the capacity one might have been similar. So it's either telling us people are really interested and enthusiastic and want to be heard, or else they're very annoyed and frustrated and they want us to find out. Could be a bit of both, I suspect. The other thing we got quite a good response across the sectors, from social care, acutes, the primary care, and also from our funded agency. So I thought that was encouraging, that it wasn't just one section. And we did get from nurses, from geriatricians, social workers, allied health professionals, social care workers. So we did get quite a good response and at varying levels. What I want to do is just give kind of the feedback. What I'm going to put up is the figures where people said that when they answered this question, they said they agreed very strongly. All right? So we asked them a certain question about the current policy. This is what a percentage said very strongly. So 74% they said they understood the policy, and we asked then another group, they understood it somewhat. Actually, that figure went into the 80%. I'm clear who the policy covers. People, 67% said, yeah, I'm pretty agreed strongly. Zero tolerance is easy to understand. 74% agreed strongly. Zero tolerance has protected people using the service. Then it dropped. Now that was, we needed to look at that and why and how we've been applying the zero tolerance approach and ethos. The policy assists me in my role and responsibilities in protecting service users. So again, these figures, those who said very strongly, you would put up another 20%, and I can get. We have the reports, and they're very detailed in terms of the percentages where people said didn't agree with, right up to agreed very strongly. And the policies help my service respond effectively to concerns of abuse. So what I was picking from this is that the policy was welcomed. People felt very strong about the human rights approach and the principles of it, but procedurally we need to really look at how we are procedurally implementing operationally. Policy clearly steps to take if I have a concern. 57% said that, and then that goes up into the 70s if you asked partially agreed. So I was reassured in that the people felt the policy has helped them recognise and respond. When we come on to actually the systems, the tools that we use, the forms, the methodology of the systems, what I call the frustration creeps in. So, okay, we asked then a number of qualitative responses. So that was kind of quantitative. People said they wanted greater clarity, and they wanted greater clarity in training around capacity, and the capacity, impact of the capacity legislation, and also the HSE's policy on consent and how that sits with safeguarding. People felt that they wanted particularly greater clarity on self-neglect and where that sits, and also in relation to definitions, particularly ones like institutional abuse that people felt was a series of descriptors, but actually didn't help you to consider what might be institutional abuse. People felt quite strongly in many cases that the policy came in without, I suppose, additional support for them as practitioners, for training, and was an administrative burden. And we need to look at that. And we also need to critically look at the type, the extent, and the degree of training input. And while people said we've had a good start with it, I think we heard a lot earlier on today and this morning how training could be improved. There was a lot of commentary on both the community referral process and the community pathways, both from primary care staff who felt that there hasn't been a designated officer in the community side, and the service side was much stronger, much clearer, and also from services feeling that it's at times they've been asked to operate outside of their scope in relation to community-based safeguarding concerns. We got a lot of feedback around how the management of peer-on-peer interactions. I'd say this one probably generated the greatest number of responses qualitatively, but we had very differing views. And I've said this a couple of times. I got in review feedback from people who said, this is domestic violence. And even one submission that wanted to make the Oireachtas were considered the new domestic violence legislation, that we should be looking at bringing in domestic violence, that right through to people saying on the other end of the spectrum, we are almost criminalising service users. So that probably generated the greatest quantity of response, but also differing views, and so that's one for a lot of thought. One that did come out, people really welcome the safeguarding teams. One of the things they said was at times that they got differing responses between teams and team members. And also there's been times where it's been difficult to get hold of the teams. So generally when the teams did reply, they got good quality response, but sometimes it was difficult. I think people feel we need to look at the email type response and at that more person-centred. Now, there are resource issues around all that. People might be aware the safeguarding teams had a 60% increase in their demand on their service between January and December. So that's something we need to look at. I think, and the last one is probably a little bit of an in-house one for the HSE, but it certainly impacts on those of you in funded services as well. The policy on the outside says HSE policy, and then you go on the inside, it says it's operational on older persons and disabilities. So the operational elements haven't been fully rolled out in acutes, mental health and primary care, and people found that confusing, difficult, and at times has led to even conflict between teams. Or whose job is it? It's mine, it's yours. Why didn't you take that? You should take that. So that was come back on the qualitative. The governance group then, and a lot of this will be a bit repetitive, so I'll go through this. We did 4 workshops, and we brought in, some of you, I think around the room, came along to some of these workshops, and we brought in members of safeguarding teams, designated officers. We also met with heads of social care, right up to chief officers, and different people within mental health teams and primary care teams. So we asked them kind of what was, from an accountability and good governance point of view, what was strong about the current policy and what wasn't working well. And people said that the policy had advanced the human rights of service users. And I suppose if they didn't say that, I'd be very worried, and that it is driving better outcomes in terms of safety for the service user. And it has led to greater clarity and framework for reporting and a framework for responding. So that was really welcomed, and that was from an accountability point of view and good governance point of view. That was. When we come down then maybe to the next two, you'll see that some of the people say what some of the strengths were. It might be a slight bit contradictory because some people felt that those were weaknesses. So there was a general view that what we now have, there's greater accountability and oversight, and has led to better planning, recording and standardisation. You'll see on the weakness side, people had lots to say procedurally about that and where there was weaknesses there. The view was that having the safeguarding team there has assisted the process to identify, to screen and to report. I suppose what came out then in the weakness, and there's a little bit of repetitiveness here, but I suppose is that there are really differing understandings around concepts, who the policy is for and what we're protecting people from. The use of language and terminology, and that is causing difficulty and frustration for people. Many came back and said that they felt there should be a reporting threshold, and the lack of one is really a difficulty with the current policy. Again, the point about the operational scope across the how am I for time?
You're just going over now.
Oh, am I? Well, I'll do a quick. So the policy needs to look at better consistency, use of resource, and our capacity and our roles. And also people said that it needs to look at the operational scope. Okay, I'll speed up now. The slides are available, so if I go over, I suppose it has left us with a number of considerations. So we're currently out there meeting people through focus groups. Our governance group is meeting with representatives of our research and evaluation group this Friday. So we are reaching a point of hearing back, I think we've had over 166 formal feedbacks. We said with the 1,400 staff that answered the surveys. So these are some of the critical questions. Do we change the language of who the policy is for? Should safeguarding be a specialist service or a mainstream model? Should we have a reporting threshold? Are Ireland ready for this? Are we still leading cultural change? Are we still at a point of actually acknowledging risk of abuse and harm in some services? So could we compromise that if we move to reporting threshold? Or should we have a more nuanced approach around reporting threshold? Where's the home for self-neglect? That's a big. And how broad should the policy be? If we change our definitions, we could be looking at areas such as domestic violence and a lot of the social inclusion areas. So where to next? We're analysing the findings. Our research and evaluation group have been chewing over some potential models and feeding that into the governance group. We need to look at those models, the implications, the risks. So we need to consider in the governance groups where we align, particularly around things like the assisted decision making, the mental health legislation, the HR policies. Looking at, I suppose, the alignment of the future policies. Really, one of the things we want to avoid, and I suppose it is a risk for us, is that this policy doesn't create unintended consequences in terms of its revision. And there are some of those problems already in the current policy. We need to carefully look where the position of self-neglect and feed all that into, I suppose, phase 3 of the review, which is the editorial right. And there's a process there of doing all of that. That's me, guys. I suppose the target is to have finished the review by year end. That's very ambitious. That was what was set out. Every time I talk to Martina, we say, will we be finished by year end? It's going to be a big task. I don't want to rush this either, because I think it's quite important. We have a real opportunity. We are mindful that there is potential legislation, but regardless of how that goes, there's a compelling case to revise. And I'm really glad the feedback we got this morning, I think, and this afternoon, and I'm delighted we've had it recorded so that we can take that feedback and bring it into the systems that we're looking at. So thank you very much for listening to me, and I hope you found that useful.